Hello, I'm Dr. Nancy Conley, the Assistant Commissioner for Forensic Services at the Department of Mental Health. I'll be talking to you today about the forensic services system at the Department of Mental Health and giving you an overview of all of the programs that we offer. Many of you are familiar with the court clinics and our inpatient service, but we also have several other programs that you are probably less familiar with. So first, I'll say that the Department of Mental Health is the state mental health authority. So we have a responsibility to everyone across the Commonwealth who has a need for mental health services or behavioral health services, not just Department of Mental Health clients. Specifically, though, we have clients of the Department of Mental Health who we provide services to and support so that they can address their mental health illness with the proper support and treatment. Forensic services in this context provide services and expertise related to individuals who are involved in the criminal justice system where there are concerns about mental health or substance use issues. So forensic services has grown over the years beyond court-ordered evaluations. Our primary task is to provide evaluations for the courts, but as most of you who are aware in the Foundation's training today, that we have many other programs that are offered as well. Interestingly, the court clinics are often the gateway to mental health services across the broader system. Often people come to our hospitals after they've been arrested for the purpose of a forensic evaluation. But once they're in the hospital, they can apply for DMH services if they're not already one of our clients. So many of our clients come in through forensic admissions. Some people come in through our hospitals from a forensic admission and do not become Department of Mental Health clients or don't apply for services. But most clients who are evaluated in forensic services are not DMH clients upon entry. So as a program, we specialize in risk assessment and risk management for the DMH system. So beyond our forensic evaluations, we also provide assessments and consultations of clients who pose a risk to themselves or others for the inpatient DMH providers and our community providers. So we do assessments and consultations across the system. And as you know, and one of the reasons you're here, I think many of you, is that we do the credentialing of forensic professionals. So I'm just going to, this is, if you look up in the slide now, this is a list of programs in forensic services. I'll speak to each program today as we go through the presentation, but just so that you know, at the top, what we'll be talking about, we have the adult court clinics, the juvenile court clinics, specialty court clinics, the inpatient forensic evaluations. We do 18A pre-arraignment screenings. We provide independent forensic risk assessments. We provide community consultations, and we have a community risk mitigation team. We have a program for mental illness, problematic sexual behavior. We have the jail arrest diversion programs. We have the forensic transition team. We have the WRAP program, which is run by the Office of Inpatient Management, but it's a Section 35 facility where our clinicians make the referrals to the WRAP program. The only way you can get into a WRAP program is through the court clinics in the court order after the hearing. We also participate in the Mass Bay Threat Assessment Team with the FBI. We provide segregation audits at the Department of Correction and some houses of correction. And again, we provide the professional certification training across the system for forensic evaluators. So just to start with the court clinic system, the court clinic system in Massachusetts is one of the few states that have their own court clinics inside the courts or something similar to that. In the 1960s and 1970s, the courts had their own system called the Division of Legal Medicine. And the laws were written at that time so that only MDs could provide forensic evaluations of the court and not necessarily psychiatry. The way the law was written was that any MD could provide a forensic evaluation. In the 1980s, the Department of Mental Health, under Dr. Robert Fine's leadership, stepped in to offer expertise and credentialing for psychologists at the time. The new court clinic system was geared to provide forensic professionals to the courts who had been trained in a consistent manner, which was not the case before the court clinic system as it exists now provided. At that time, only psychiatrists and psychologists were given the authority to be evaluators. The social workers, the QSWs, qualified social workers, weren't added until 2014, so quite a while later. The social workers were allowed to be qualified to provide Section 35 evaluations. Now, all of the district courts, the BMC courts, the Boston Municipal Courts, Superior Courts, and juvenile courts have access to our court clinic clinicians. We also provide staff to the specialty courts, and the oversight for that credentialing is done by the courts themselves, not by the Department of Mental Health. And we do provide evaluations for probate, land, and housing. So I just want to, you can look at the slide and you can see the number of courts that we're covering: 62 district courts, 9 BMC courts. BMC is similar to district court, it just has a different administration. 17 superior courts, 40 juvenile courts. The number of specialty courts goes up and down, but there are probably about 40 at this point, and DMH provides clinicians for most of them, not all though. And the Section 19s are provided for all of the other courts, which generally are the evaluation of witnesses who appear in the various other courts. So I'll start with the adult court clinics. And most of you are familiar with the types of evaluations that are conducted in the court clinics now, which I have listed on the slide. But I want you to know that becoming almost an entirely evaluation service is new. The court clinics used to provide more services than evaluations. They used to provide consultations to the probation departments. Some did treatment. Some were kind of a community type open door where people could come in and ask questions in the court clinic about mental health referrals. At this point, primarily because of the volume of cases that we do, the number of statutory evaluations that are ordered, we've become an evaluation service and somewhat more of a mobile service as well, where different clinicians will cover multiple courts. And a lot of this is the result of the demand for Section 35 evaluations, which has increased the number of evaluations that we have to do significantly over the years. So you can see from the slide that we do Section 12E evaluations, which are the civil commitments due to mental illness and the need for hospitalization, the 15A screenings, which are done in the court clinics, the competence to stand trial and criminal responsibility, the Section 35 civil commitments due to alcohol or substance use and the likelihood of serious harm to self or others, the 18As, the need for hospitalization for already incarcerated individuals while they're awaiting trial or sentenced and they're in a correctional facility and they need a higher level of psychiatric care. And Section 19, as I mentioned, the evaluation of a witness in any type of a matter across the court system. I also want to mention the 18A and a half, where the court clinics are not doing any evaluations. This was a new law that was enacted in 2023, which allows prisoners who are already incarcerated to file petitions directly to the court that would allow them to be transferred out of the correctional facility into a hospital, either the Department of Mental Health or Bridgewater State Hospital. The conditions are that the person has to pose a likelihood of serious harm to themselves, just says self, it doesn't say to others in the law, and has been on a mental health watch for 72 hours. The facilities are required to inform the prisoners of their right to ask for an 18A&a-half transfer, which has happened since the law passed. Right now, the impact has been primarily towards Bridgewater State Hospital, which has had at least 80 transfers from the correctional facilities. The Department of Mental Health has only had a handful, primarily women, and it's been under 5 cases since the law was passed. Our court clinic responsibility, which is not written in the law, but which we agreed to just because it would help facilitate the process and prevent any kind of disruption in the Department of Mental Health, is we've asked the courts to contact the court clinic if a bed is needed for an 18A&a-half, and then we will help facilitate the bed finding. So that would be our only involvement. We're not doing a clinical assessment. It's also an evolving situation, so we'll see how this unfolds over the years. I also like to highlight the Section 35 because it's our highest volume evaluation and puts the most demand on our staff. The Section 35, as many of you know, is the civil commitment due to alcohol or substance use and the likelihood of serious harm to self or others. What you need to know is that 70% of our adult court clinic cases, which is about 4,000 cases per year, are Section 35. So these 4,000 is an estimate. The number changes year to year, but it's the majority of our adult court clinic cases are Section 35s. And for those of you who are involved in this, you know that the case must be heard the same day as the evaluation is ordered. So if the case comes in at 9 o'clock in the morning, you have pretty much all day to do the evaluation, get the collateral context, and locate the bed. But if the case comes in at 4 o'clock, you just have until pretty much 4:30 to do the same amount of work. So it puts great demands on our staff and on the courts to be able to accomplish this all in one day. And both qualified social workers and designated forensic psychologists and designated forensic psychiatrists can do the Section 35s. The beds are at the Department of Mental Health, or BSAS, which are the public beds. The Department of Mental Health has the RAP beds, which I mentioned earlier. The Department of Correction has beds at MASAC, and the Hampton County Sheriff's Department has Section 35 beds as well. We need to make a note that the juvenile beds are a problem throughout the system. There are only 6 Section 35 beds. So whenever there's a Section 35 commitment by the court, we run into a problem with being able to access a Section 35 bed. It's an unsolved problem at this point right now. So the other thing I wanted to mention for those of you who are involved in Section 35 evaluations, you should read the Section 35 Commission report from 2018. It discusses various controversies surrounding Section 35, and there are different advocacy groups and government agencies who are involved in these discussions and were involved in the commission. There's discussion around the harm reduction model, voluntary models versus mandated treatment or involuntary treatment like Section 35. And all of these issues were reviewed for the commission. They keep coming up over the years, though, so they haven't quieted down. When you're doing Section 35, you should be aware that these discussions are ongoing. Over the past several years, there have been several legislative bills filed to close the carceral settings, or the carceral settings are the correctional settings, which are the Department of Correction and the Sheriff's Department. This was done for women several years ago. And one reason the RAP program in the Department of Mental Health, which was originally for women only, it wasn't for men, was developed because the law changed that didn't allow women to go to MCI Framingham just for Section 35 civil commitments. If they had criminal charges, that was a different story, but you couldn't send a person to MCI Framingham for Section 35, which was done in the past. So there's still ongoing discussion about whether men should be sent to carceral settings under Section 35, or whether they should all be Department of Public Health or Department of Mental Health beds. Also, if you need the Section 35 commission report, we can send that out to you. Heidi DeLeone can send it out, or you can just go on a link and look it up, and it's online. Most of you are aware that in addition to in-person evaluations, we are also using video conferencing for evaluations. Since the COVID pandemic, we've been doing remote evaluations. When the pandemic started, we had to learn how to conduct evaluations in a clinically sound, ethical manner because the courts had closed. There was a lot of concern about interviewing patients in person. Our clinicians were working from home at the time, and we needed to figure out how to do the evaluations that were still being ordered, particularly under Section 35. As it turned out, the American Psychological Association had been dealing with telepsychology for around 20 years, so it was before the pandemic. So there was quite a bit of information for us to access to be able to do our evaluations ethically and in a clinically responsible way. And so we required our clinicians to take the APA trainings, which were free at the time. During the pandemic, they opened it up so that everybody could go on and learn about how to do telepsychology. And there are things to think about related to privacy and platforms that you're using that you wouldn't have known if you hadn't done video conferencing in the past. So we encouraged everybody we actually required everybody to take the APA trainings. And what we also learned from APA was that there had been research done previously about competence to stand trial evaluations that were done virtually and comparing them to in-person evaluations. And the studies were not huge, but they consistently showed that if you do an in-person evaluation or if you do a virtual evaluation, you will come up with the same recommendations, that it didn't change the outcomes, which was good to know. There's no research on Section 35s that is similar, but the competence to stand trial has pretty much held up as not changing the outcomes if you're doing virtual or in person. I'm still concerned about the quality of our technology, particularly in some of the older courts where the reception isn't good. The interviews are take place down in the lockups where sometimes there's a lot of noise and sound. And some of the post-COVID research talks about less than ideal conditions for evaluations, so in poor quality technology. So far, we haven't heard anything that suggests that it changes the outcomes or the recommendations, but we need to pay attention to that over time. Obviously, initially, we did the remote evaluations because of the pandemic, but now we actually do it because we need to stretch our staff. We had initially a pilot project after towards the end of the pandemic to try to figure out how we were going to deliver our services remotely. And we originally called it the Court Clinic Remote Response Pilot Project. And at that time, plan was to conduct statutory evaluations remotely by video conferencing. And our clinicians could be located anywhere across the state, whether they were at home, whether they are in another court, but they could respond to courts all the way across the state. They could be sitting in New Bedford and take a case from Lawrence. It didn't. We treated everybody as a statewide clinician. Again, it was driven by the post-pandemic staffing shortages, and also it allowed us to have same-day responses. Remember the cases that come in at 4 o'clock. If we don't have somebody in the court, it's very hard to do that. But if we do it remotely, we can move the case along. And originally, we planned to focus on the late day evaluations because it's harder to get from one court to the next. But it turns out that now we're pretty much using it for all day long. But at the beginning, we were thinking, well, this will deal with the late day evaluations. We also are very aware that it maximizes staff utilization. If we only have staff in New Bedford and we don't have staff in Lawrence, and we can use that clinician for the Lawrence evaluation, then we can maximize our ability to use every single clinician that we have available. What we discovered also is that it was helpful with staff retention because some people like the idea of being able to do remote work, usually from their home, 1 to 2 days a week. And that worked for them and it worked for us. So it actually turned out to be pretty a bonus for the staff who wanted to do it. Nobody's was required to do it at the time. This was the pilot project. So we had the statewide remote service, which began in response to the pilot, which was a success. We decided, okay, we're going to do this permanently. That started in January 2023. Right now, we have 25 clinicians, and they cover 1 to 3 days per week remotely. In the first 150 days of operation, we did 600 evaluations. It's way more than that right now. The service is really growing. We're really dependent on the service at this point. But just to put it in perspective, about 25 to 30% of our evaluations are done remotely, and 70 to 75% are done in person. We also provide clinicians for the juvenile court clinics, and similar to the adult court clinics, we do competence to stand trial and criminal responsibility evaluations and Section 35s. But additionally, juvenile courts have other functions, and we provide the evaluations for child requiring assistance, CRAs, which are non-delinquent matters. The term delinquency is used instead of criminal in the juvenile court system. And that is what some of you might remember as the old Chins law, which are for habitually absent students, which would be the truancy laws for runaways and what is still referred to as stubborn child. These are youths who need assistance with being able to access various services to help them become either less truant or not run away, or be more involved with the requirements of their schools and families. So both schools and parents can file CRAs. Additionally, we do 68A, which are comprehensive assessments for delinquency. So that's when there's actually been a delinquency petition filed, and that can be pre or post adjudication. And our clinicians involve the families, collaterals, other agencies, and the youth in order to do a 68A. It's a diagnostic study, but it also comes up with recommendations for the courts on how to proceed with the youth. We also do some care and protection petitions, which are usually filed by DCF when they are asking the court to remove a child from the home because of abuse or neglect. Our court clinics do some of the CNP evaluations, but most are done by private practitioners. A few more words about the juvenile court clinics, which unlike the adult court clinics, where the numbers are growing, the juvenile court clinic referrals have been going down. Much of this can be attributed to the juvenile justice reforms that have occurred over the years, formally in 2018. But most of the reforms that have been enacted over the years have emphasized keeping youths out of courts and keeping them away from law enforcement involvement, and rather providing community resources and diversion programs so that youths don't become involved in the criminal justice system. So that has really had an impact. There are fewer cases in the juvenile courts because of the focus on diversion. And as a result, if they're not in the juvenile courts, they're not going to be in the juvenile court clinics. What our court clinicians have told us, though, is that the cases that we get in our juvenile court clinics now are more complex than they have been in the past, because either diversion efforts have been attempted and they've failed, or the youth has been bypassed and has missed some opportunities for intervention. And now the youth is in the court clinic with either more serious delinquency matters or with older and more serious psychosocial problems. So we're seeing more complex cases and higher level of risk by the time the person reaches the Department of Mental Health in the court clinics. So our court clinicians are dealing with the cases that have not been successful with diversion or community supports or other interventions. One of the issues with the diversion programs and the community resources is that they're not really always available to people. There are wait lists. They're always voluntary, so if people don't want to attend, they don't need to, and possibly have people have difficulty accessing some of the community programs. So they haven't always been available to the clients who then eventually end up in the court clinics. And I would argue that our clinicians have expertise related to risk and risk assessment and treatment that many of the community providers do not have. So we have a specialized expertise in risk assessment, which I don't really think is available in most places in the community. And our courts rely on us for that purpose. They want to know what our opinions are about risk and to help solve some of these systemic problems that are faced with, well, how are we going to gain access to community services and assist the youth with the rehabilitation efforts and keep them away from further criminal justice involvement. Forensic Services also is involved in the hiring of clinicians for the specialty courts, but we do not have direct oversight, which I mentioned before. The Department of Mental Health does not credential the specialty court clinicians. This slide used to have the number of specialty courts, but it changes all the time, so the numbers weren't always accurate. So I've left it just to let you know what types of specialty courts are available. The adult drug courts, the veteran treatment courts, homeless courts, family resolution court, family drug court, juvenile drug court, and mental health courts are all different kinds of specialty courts. The focus of the trial court has been on offering adult drug courts, which are also for alcohol. And their goal was, the court's goal was to have a diversion program available to every person who came in with drug or alcohol related offenses, so that they could access services and possibly prevent incarceration, where they were seeing people cycling in and out of brief periods in jails, coming back out and then having the same substance related problems, and then just circling back through the criminal justice system again. So it was an attempt to, it is an attempt to get to people's treatment that they need, so that they don't keep becoming engaged in the criminal justice system. So that's been, no matter where you live in Massachusetts, or wherever you get arrested, you will have access to a drug or alcohol court. There are exceptions. Not everybody can use the diversion, particularly if there's a violent offense. So not everybody is eligible for the specialty courts, but lots of people are. I would say most people are eligible. The mental health courts are specifically for people with mental illness, and providing case management services and other supports, so that they can gain access to the services they need. So we really see that being very consistent, both the drug courts and the mental health courts, as being very consistent with what the Department of Mental Health does. So we also have our inpatient forensic evaluations that I think many of you are probably aware of. They're the court-ordered evaluations after our court clinic screenings and after the commitment hearings, when the person has been sent to either the Department of Mental Health or to Bridgewater State Hospital for further evaluation, observation, and then provides recommendations to the court about the psycholegal issue. So these are primarily for competence to stand trial and criminal responsibility evaluations. We offer an opinion to the court, and the court will make decisions based on our opinion and whatever evidence is presented during the hearing. We do section 15Bs, 16 and 18. There are some presentations later that go more specifically into chapter 123 evaluations. The evaluations are conducted at Worcester Recovery Center and Hospital, Tewksbury Hospital, Fuller Hospital, Shattuck, and Taunton State Hospital. Our inpatient evaluators do the evaluations. They write a report, and it goes back to the court so that the criminal procedure can move forward. And additionally, in Massachusetts, our clinicians write a section on care and treatment. They make recommendations about what kind of further care and treatment is needed. And a more recent development that we've been trying to tie our forensic risk assessment to our community risk assessments is by asking our forensic clinicians to edit their care and treatment sections and enter it into our medical records so that our inpatient staff has access to the information, and then eventually our community providers has access to the information. So we do these very elaborate risk assessments, and then the information gets sent to the court. But in the past, the information wasn't communicated to our own inpatient DMH providers and our community providers. We're trying to make a link between forensic services and our inpatient providers and our community providers by using the information that we gather from our reports of our evaluations so that everybody can have access to that specialized assessment. Just to mention the 18A pre-arraignment screenings, which I don't think most of you are familiar with. These are evaluations that are conducted when a person is in the police lockup and cannot be safely managed due to mental illness or suicidality. It allows for a temporary psychiatric hospitalization prior to when the person is arraigned, pre-arraignment, but it only occurs when the courts are closed. So these evaluations take place in the evening after 4:30, after the courts are closed, at night, on weekends when the courts are closed, or on holidays when the courts are closed. Our evaluators do the evaluation, and then there's an on-call judge who can order a commitment. So in order to do these pre-arraignment screenings, the emergency services program, whoever is providing that service, is involved, and DFPs, our forensic professionals, are involved to determine whether the person needs to be hospitalized. The police will contact the emergency services and say, hey, we think we have somebody here who's suicidal. We're not sure that we can keep them in lockup for this period of time until tomorrow, until over the weekend, and before they can get to court to be arraigned. So can you take a look at them to make sure that they're safe? So if the person appears to be safe enough to stay in the lockup, then there's no hospitalization. But if there does seem to be an increased risk, then the designated forensic clinician will evaluate the person and then contact the on-call judge and make a recommendation for hospitalization. The person can go to the Department of Mental Health or Bridgewater State Hospital for the period of time until the court opens. So it's not a lengthy hospitalization. It's just until the court opens, and then the person is transported for arraignment to the court. So that's been what we learned during the pandemic, was that when we did video conferencing for these, it was more accessible to police departments, and actually they found it easier to use us virtually than waiting for the clinician to arrive at the police station or the hospital, the emergency department of the hospital, to evaluate. So we've actually continued to do this primarily remotely at this point. We are still doing some in person, but the police departments find that it's easy for them to be able to access us through video conferencing. Okay, so Forensic Services also does specialized risk management evaluations. We have our independent forensic risk assessments, IFRAs they're called, and you'll hear the term IFRA, which are risk assessments of inpatients with histories of violence towards other people, who the inpatient teams are asking for a consultation because the person is going into the community unsupervised, or the inpatient team is recommending that the person be discharged to the community. So we have a list of mandatory IFRA requirements. And the requirement is that if a person has had a certain offense in their history, it's mandatory to get an IFRA. So the offenses are murder, manslaughter, kidnapping, rape, mayhem, assault and battery with intent to murder or intent to rape, assault and battery with intent to murder or assault with intent to rape, indecent assault and battery on a child, and arson. We've also added electives, which we often do for stalking assessments, and I'll speak to you about the level 3 sex offender evaluations as well. But anybody who comes into our inpatient units with one of those charges in their history is required to get an IFRA evaluation before they have unsupervised access in the community or before they're discharged. We also have mental illness problematic sexual behavior evaluations, and that's for both inpatients in Department of Mental Health facilities and community assessments for anybody who has had a history of sex offending, which they've been charged or convicted of, or for problematic sexual behavior, which they may or may not have any criminal charges related to it. But we do a specialized assessment of their risk for sex offending or problematic sexual behavior with our MIPSB evaluators. So the other thing is that similar to the IFRA evaluation, before a person is discharged from our inpatient facilities, if they're a level 3 sex offender, which is determined by the Sex Offender Registry Board, if they're a level 3 sex offender, we provide a level 3 protocol, which involves a specialized assessment from our MIPSB team. And essentially what we're looking at for both the IFRAs and the MIPSB level 3 protocols are, does the discharge plan have sufficient risk mitigation measures in it so that the discharge is a safe discharge, that we provide the services that are needed so that the person can go into the community safely with reduced risk. We know that risk is fluid, it goes up and down, but at the time of discharge, have we put something in place that does our best at risk mitigation? We also provide community consultations, and this year we've started up a community risk mitigation team, which I'll talk about. So our community risk mitigation team is a group of forensic clinicians who have been assigned to each DMH area to provide consultation and ongoing support for high-risk cases, and this is high risk for violence. We've been doing community risk assessments for several years on an ad hoc basis, but now we actually have a dedicated staff and a dedicated team for it. Our community providers are seeing higher risk individuals in the community. We're hearing about this all the time, that they're seeing people that pose risk of violence in the community and are looking for specialized consultation on, well, how do we mitigate this risk? Historically, a lot of our focus has been on our inpatient population, on doing the specialized risk assessments for them. But now we've actually started to work with the community providers who definitely have people who are at high risk. And if you think of it, if persons in the community and they have access to substances, they may have an unstable living situation, they may have relationships with conflict, the risks can go up pretty quickly, pretty fast. So I think we need to have risk mitigation consultation as all these events occur over a person's lifetime and while they're in our care. So our teams will support the risk management strategies like at discharge, but also over time. We also view this as the bridge between forensic admissions and forensic services inpatient and the inpatient treatment to our community services and our community treatment programs. We also have our jail diversion programs. The Department of Mental Health has been involved in jail diversion programs since 2007. This is a partnership between the Department of Mental Health and the police departments with the goal of diverting people in mental health crisis to proper services and not arrest. We strengthen through our programs the law enforcement responses to people who are experiencing behavioral health crises. DMH has been involved in two approaches. One is to train police in mental health issues and how we understand and de-escalate high-risk situations using clinical strategies. And the second approach is to send clinicians on call with the police to intervene directly while the crisis is occurring. The first type of program that I mentioned is the police training model, and it's called CIT, Crisis Intervention Team. And this is directly training police officers who will be going out on calls themselves and first responders on mental health and behavioral health issues. These officers have contacts with crisis teams all the time, emergency services all the time, but we're building up their skill set in terms of understanding behavioral health issues. You can divert an arrest even after the police have been called. If 911 is called, the police go out. They don't have to arrest a person at that point. They can divert them into services or programs. So in these cases, the police officers are alone without clinicians, but they've had training on how to intervene and understand if it's clearly a mental health issue or substance issue that's in front of them. And so they use that training when responding to calls. And some police have been very engaged in this and have sought extra training, and they go through training over the years. It isn't just kind of a one-time training and then we're done. They're involved in becoming better informed about mental health and substance issues. The second model is the co-response, and that's probably the one that most of you are more familiar with. This is when a clinician is embedded in a police department and co-responds with the police officers. They actually, when the 911 call comes in, they actually go with the police to the crisis. And they can assist the police with intervening if there's a mental health issue, with de-escalating the situation, talking to the family members. They can be of assistance in a number of ways. But in addition to just going out on the calls, they can also be available for follow-up. If it's a family who's called the 911, then clinicians can meet with the families later or meet with the client later. It isn't just crisis intervention. They can follow people over time to try to maintain some stability rather than having to wait till something becomes a crisis and becomes a 911 call. The clinicians are also available to police departments just in general for behavioral health issues. So if something happens when the clinician's not there, if something happened overnight, then they can consult with the officers who are on the calls and just be available for that kind of information or referral, available resources, that sort of thing. And the whole idea with this is to create alternatives to arrest and incarceration by intervening early during a crisis and intervening in an ongoing way so that you don't have to wait for a situation to escalate. The Department of Mental Health has funded a certificate program at William James College for this purpose. DMH is also, as I said, directly involved with the police training and with the co-response clinicians. The Department of Mental Health also has a forensic transition team. And these are DMH clinicians who are assigned to jails, houses of corrections, and prisons in order to follow DMH clients who are incarcerated. They already are clients, but they've been incarcerated either pre-trial or they've been sentenced. So our FTT team coordinates with the person who's incarcerated. They track where they are, when they're going to be released, their treatment that they received while they're incarcerated, and prepare for services to be available for when the person is released from the incarceration. So it's a continuity of service issue that you'll, if you are incarcerated but you're a DMH client, will follow you through that period so that when you get out, your services will be established and be available for you, and your medications will be available. There'll be things that can be done before you're released to ensure that the transition is smooth. So this is a statewide service. We do it all across the state. And again, it's focused on the continuity from correctional facilities to the community. Okay, so I mentioned the RAP program, which is the DMH inpatient program for both women and men who are committed under Section 35. The program was designed to focus on co-occurring disorders, both mental health and substance. So people are prioritized if they have a co-occurring disorder as opposed to just a substance use issue, which is addressed in Section 35. So the reason it's on our forensic roster is that all of the patients who come to the RAP program come through our court clinics. You have to be evaluated in our court clinics under Section 35 and be committed by a court in order to get into the RAP program. There are no community intake procedures or anything. It is designed specifically for Section 35. DMH is involved in community risk assessment, as I've mentioned, but also community threat assessment. We work with our providers on identifying clients with higher risk for violence and risk mitigation, which I've talked about. But as an extension of our community-based intervention, DMH has joined the Mass Bay Threat Assessment Team. This is a multidisciplinary threat assessment team led by the FBI, and their goal is the prevention of targeted violence. And targeted violence would be school shootings, threats of terrorism, stalking, threats towards elected officials, that sort of targeted violence, which usually involves multiple victims. The Department of Mental Health becomes involved. We attend the meetings, but we become actively involved when the person who's being reviewed has a diagnosable mental illness. And our strategy is to engage them in services. The Mass Bay Threat Assessment Team is made up of law enforcement, mental health, school, community agencies. It's very well represented by different people in the community and have different perspectives. And the team can consult on any of these cases. DMH actually steps in and we reach out. One of our clinicians reaches out if there's a diagnosable mental illness. And there are a significant number of the evaluations, the consultations that are done have mental illness that are involved that we can intervene. A significant number are youths. We have had a number of youths who have been referred after they've made threats about blowing up their school or shooting their classmates. And our clinician can go out and contact the family. We've also used the jail diversion program co-responders for this purpose as well. Meet with the family, meet with the youth, engage them in services. And just last year we had over 60 cases that we were engaged in. So it's actually quite a few families and youth who have been able to be in touch with. Some of that number are adults as well. The adults sometimes are presenting with delusional disorders that they're often not especially receptive to mental health intervention. So we understand that they have a diagnosable mental illness, but if they decline treatment, then there's really not much else we can do. And then the cases tend to take a more law enforcement, criminal justice route at that point where criminal charges are filed. But if we can intervene with anybody who needs access to mental health services or social services, we do that. So we've been involved in that since the Mass Bay Threat Assessment Team started a few years ago. Forensic Services is also involved in segregation audits, which started, we were required in July 1996 to begin providing inspection teams to conduct on-site visits at the Department of Correction segregation units and to review the medical, dental, and psychiatric services. And our team assesses whether the services are adequate. Our team is psychiatry, a physician, nurse practitioner, and Department of Mental Health has an audit team coordinator who attends as well. The DOC facilities that have a segregation unit, which now more recently have been called behavioral assessment units, are visited by the audit team. They go into the facility at least annually and review the care that is provided in the facilities and speak to some of the inmates who are receiving services, and then reach conclusions about whether the services are adequate, and then they can make recommendations for additional follow-up or other corrective actions if they're needed. The audit team, in addition to the Department of Correction, also monitors the Hampden County men's and women's facilities and the Middlesex County House of Correction. So some of you are here for our certification and training purposes, the foundation training. You know that the Department of Mental Health oversees the certification of the designated forensic professionals for both DMH and Bridgewater, and the certification of the juvenile court clinicians, the CJCCs, and the certification of the adult and juvenile social workers, the QSWs, for Section 35s. In addition to the certification process and the trainings, we do our annual training, and then we provide specialized forensic training for both our inpatient and community providers and everyone who's working in our programs. I would encourage you to keep an eye out for our learning series as well. Our learning series is specifically directed to our staff. It's sometimes difficult to get the kind of training we need because we are such a specialized service, but our learning series that we put up once or twice a year are designed just for our staff to deal with the issues that they're concerned about. So it's very focused, and I think you'll find them beneficial. We also do the certification for sending facilities for 18As. And we've added the 18A and a half evaluators. It isn't in the law that we're required to do it, but for consistency with 18A, we are providing credentialing for the 18A and a half evaluators as well. So just to give you a summary, the Forensic Services role in the Department of Mental Health is that we provide forensic evaluations ordered by the court. We provide risk assessment and risk management across the service delivery system, and we provide consultation to inpatient and community providers for risk assessment and risk management. Okay, so thank you all for participating. For those of you who are in the foundations training, I appreciate that you're working with us in forensic services and hope that you'll be long time forensic clinicians. Thank you.